Good morning. So today we'll be running a mock mega code. So who will be the team leader?
I'll be the team leader.
Okay, so I'll be giving a scenario to you. You are working in the cardiac care unit of your hospital. A woman who underwent PCI 3 hours ago is reporting heavy central chest pressure and nausea. That is the case.
Okay. So good morning team. Good morning team. Today I'll be leading a resuscitation scenario, ensuring that following of a AHA ACLS protocol. So before going to start, first I'll be pre-briefing the case for you. A woman who underwent foreign PCI 3 hours ago. Now she was reporting for a central chest pressure and pain. So I'll be assigning a roles for you. So Raisa, you can take care of the airway. Anand, you can take care of the compressions, ensuring that we are supposed to provide of high qualities of CPR and also use of feedback device. Ashwini, you can take care of an IV and medications. Nandini, you can take care of a timer. Akash, you can take care of a cardiac monitor, and also you are supposed to act as a CPR coach. Can we begin, ma'am?
Yes.
Anand, could you assess the responsiveness of the patient?
Ma'am, are you okay?
Is the patient is responding?
The patient appears drowsy, pale and diaphoretic.
Okay. Akash, could you connect for the cardiac monitor to the patient? May I know the vitals of the patient, ma'am?
Yes, heart rate is 130 per minute. BP is on the lower side, it's 72/40. Respiratory rate is 20 and temperature is 37 degrees Celsius.
May I know the patient age?
It's 51 years old.
Okay. Ashwini, could you secure an IV access? And as the patient is complaining for chest pain, you just give pain medications, injection, morphine, IV, 2 mg.
IV line secure, 2 mg morphine given IV.
Can you connect to the oxygen supplementation? Can you start on oxygen supplementation? So the monitor is showing a wide complex regular tachycardia. So it is a VT monomorphic. Could you check for pulse?
Pulse is present.
So the patient have pulse and the vitals is showing a patient is in unstable condition. So we are supposed to proceed for synchronized cardioversion. Before going for synchronized cardioversion, we are supposed to first sedate the patient, take a consent and then keep the crash cart ready. So Ashwini, you can prepare for us sedative medications. Nandini, you can go and take a consent from the bystander. Select 100 joules of energy. Turn on the sync button.
Synchronized cardioversion.
Charge it and keep it ready.
Synchronized
Consent is
cardioversion.
taken, sedation is given.
So we can proceed for synchronized cardioversion. Could you remove the oxygen source? You can proceed. Everybody clear? Do not touch the patient. Wait for 10 seconds. Is showing any effectiveness for the first synchronized cardioversion?
No, the rhythm is the same.
So we will be proceeding for a second synchronized cardioversion. Could you increase the energy to 200 joules? Okay, as the sync is on, so just charge it and keep it ready.
Synchronized cardioversion.
So still the rhythm is same?
Yes.
So as the rhythm is still same, it is showing a VT monomorphic. We can proceed for second synchronized cardioversion. Remove the oxygen source. You can deliver second synchronized cardioversion. Everybody clear? Stay for 10 seconds. Okay. So Akash, could you turn off the sync so that I can see the rhythm clearly? So the rhythm is showing a ventricular fibrillation. Anand, could you check for pulse?
Pulse is absent.
Present? So as pulse is absent, you can immediately start compressions, ensure high quality compressions, give ventilations after every 30 breaths. Meanwhile, you can charge for 270 joules maximum and keep it ready. Charge it. Once it gets charged, inform to me so that we can deliver the shock as soon as possible.
Stock is charged.
Pause compression so that we can deliver shock. Everybody clear?
All clear. Shock is delivered.
Resume compressions.
1, 2, 3, 4, 5, 6, 7, 8.
So timer person, could you inform me that once it is finishing of 15 seconds to 2 minutes so that I can pre-charge the defibrillator and also I can check for pre-pulse check over the femoral artery.
29, 30.
Could you load for epinephrine 1 mg 1:1000 dilution and be prepared?
6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. 1, 2, 3, 4, 5, 6, 7.
Ensure that you are giving off high quality of compressions.
30, 40, 50, 60,
The quality is high, continue the compression.
20,
Okay.
21, 22, 23, 24, 25, 26, 27, 28, 29, 30. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
Once after finishing of 2 minutes, you can switch over the compressors also.
15 seconds more.
So you can pre-charge the defibrillator, you can check for pre-pulse check over the femoral artery.
Pulse is checked.
30.
No pulse. Okay.
The shock is charged.
Okay.
2 minutes over.
30.
You can deliver the shock. Meanwhile, you can switch over the compressors also. Deliver shock now.
All clear. The shock is delivered.
Okay. So now the rhythm has changed. So could you check for pulse?
Pulse is absent.
So resume CPR. Pulse is absent and the rhythm is showing a white complex regular with P wave. So it might be a pulseless electrical activity. Could you give epinephrine 1 mg 1:1000 dilution followed by a flush?
Flash given.
Okay, thank you. And CPR coach, could you monitor the quality of CPR continuously?
The good quality is CPR, continue.
Okay. Team, what could you think that what might be the cause of this cardiac arrest?
I think the patient recently went to the PCI and done a coronary intervention. It could be coronary thrombosis.
Okay, then once after a resuscitation has been completed, we can think about a coronary intervention later. So you can prepare the next dose of epinephrine and you can give on an average interval of around 3 to 5 minutes, okay?
Epinephrine preloaded.
15 seconds more.
You can pre-charge the defibrillator with the maximum joules. You can pre-pulse check over the femoral artery.
Pulse is checked.
Pulse is absent.
Okay.
Shock is charged.
Okay, thank you.
2 minutes over.
Pause compression, could you check for pulse?
Pulse is absent.
Okay, continue CPR. Ensure we are giving of high quality of CPR and we are not giving of more depth. We are maintaining around a 5 centimeters depth, maintaining a rate of 100 to 120 compressions per minute, and we are not giving of excessive ventilations and allow complete chest recoil and minimize the interruption time. Once you have become tired or after 2 minutes, you can switch over the compressors to maintain the high qualities of CPR. So the rhythm has been changed. Could you pause compressions? Could you check for pulse?
Pulse is present.
Well done team, we have achieved return of spontaneous circulation. Now we can proceed for a post-cardiac arrest care protocol. So first we are supposed to assess the airway of the patient, as we have not intubated during the resuscitation scenario. Now you can intubate the patient and secure the airway. And regarding the breathing part, you are supposed to set a respiratory parameters around SpO2 should be maintained more than 92 to 98%. And regarding the respiratory rate, the breath should be around 10 to 12 breaths per minute, and PaCO2 should be maintained in between 35 to 45 millimeters of mercury. Then coming to the circulation part, the hemodynamical parameters, we are supposed to maintain a SBP more than 90 millimeters of mercury, and the MAP should be maintained more than 65 millimeters of mercury. May I know the blood pressure of the patient?
It's on the lower side, it's 80-40.
Okay, now we can consider for IV fluid administration. Initially, we will be seeing whether the patient is responding to a IV fluids or not. We can start the IV fluids 1 unit bolus.
IV fluid started.
Now at this time, we can take a 12 lead ECG and you can see for any STEMI changes were there or not. Could you take a 12 lead ECG?
The 12 lead ECG.
You're able to see ST segment elevation.
So as the 12 lead is showing a STEMI changes, so it might be a ST elevation myocardial infarction. We can consider now getting a cardiac consultation and considering for a coronary intervention. Now we are supposed to see whether the patient is like following commands or not. If the patient is following commands?
No.
So as the patient is not following commands, you are supposed to do a targeted temperature management around 32 to 37.5 degrees centigrade and take a brain CT and take a EEG monitoring and shift the patient to an ICU and monitor the patient for at least 24 hours. So now we have resuscitated the patient well. Now we can go for a debriefing session. Before going for a debriefing session, team, we can gather, analyze and summarize, and this feedback will be effective and helping for the further resuscitation scenarios. So from your side, is there any feedback?
The quality of CPR was good.
Okay.
During the whole workout time, 1 mg adrenaline was given.
Okay.
The core time was 5 minutes, 30 seconds.
So okay, could you calculate the CCF and could you tell me?
Yeah.
So shall I start the debriefing session?
Yes.
So we have received a patient who underwent for PCI 3 hours ago. Now she is reporting for a central chest pressure and pain. For that, first we have assessed the responsiveness of the patient and we have seen the patient is not responding. Then we have connected to a cardiac monitor and we have got the vitals that the saturation is not recordable and the patient is in a hypotensive. So first we have attached oxygen supplementation and then we have seen the rhythm. The rhythm is showing a VT monomorphic with pulse. And we have proceeded for a synchronized cardioversion. Before going for that synchronized cardioversion, we have prepared a consent and given a sedation and prepared for a crash cart ready. Then after giving a first synchronized cardioversion, the patient is not responding and the rhythm is not showing any effectiveness. Then we have proceeded for a second synchronized cardioversion, and after second synchronized cardioversion, we have seen a rhythm change has been there. So, and the rhythm is like showing a ventricular fibrillation and we have checked for the pulse. The pulse is not there. So immediately we have started a CPR and I have asked to deliver first shock immediately as soon as possible, and after delivering of the first shock we have wait for again a rhythm change. After 15 seconds to 2 minutes we have pre-charged the defibrillator and we have done a pre-pulse check. After 2 minutes again it's showing a ventricular fibrillation without pulse, so we have delivered second shock. Immediately we have waited for the response. At that time the rhythm has been changed to pulseless electrical activity. So we have resumed the compressions and we have given first dose of epinephrine 1:1000 dilution 1 mg. Then we have waited for the response. Then after 2 minutes we have seen a rhythm has been changed and it is showing a sinus rhythm. So immediately we have checked for the pulse and the pulse is present. So at that moment we have achieved a return of spontaneous circulation and we have stopped our resuscitation efforts. Then we have went for a post cardiac arrest protocol and we have managed the patient, and as the patient is not following commands, we have done a targeted temperature management and we have secured a airway and we have set a parameters regarding the breathing and circulation part.
So you and your team has done the resuscitation attempt really well. I'd like to appreciate you for that, and I'd like to specially mention about the pre-charging and pulse checking that you have done accurately. Not just that, you have done all the interventions, necessary interventions at the right time, and you have achieved a chest compression fraction of 81%. That's really great about you and your team. So congratulations all of you.
Thank you.